2,500 patients. Next slide. The project was rolled out in 3 phases. The first phase consisted of the following components. Can we have the next slide, Amy? Thanks. Nursing checklists were developed to capture transfer information for pre- and post-hospitalizations. The pre-checklist included such information as the comorbid conditions, the dialysis prescription, vital signs and weights for the last 3 treatments, hepatitis status, and a notification of an alert bracelet for the access arm. The post-checklist included a list of what to address during the first 3 treatments after the patient returned to the clinic. The most important of these, of course, being medication reconciliation, as well as getting orders for hemoglobin and albumin and doing a fluid assessment and adjusting dry weights. Crit lines were provided in the right track clinics, and clinical evaluations included nutritional status and supplements if necessary. A red flag patient teaching tool was also created. These were teaching sheets for the most common reasons for admissions, being fluid overload, heart conditions, pneumonia, high potassium, vascular access, catheter infection, GI condition, foot and leg infections, diabetes, and depression. These sheets allowed the nurses to determine if patients understood reasons for admission, what the patient might do to prevent a reoccurrence and a rehospitalization, and a confidence scale to determine whether the patient felt they could manage their care. Next slide. Phase 2 introduced case managers. The goal was to have a case manager contact every discharged patient within 72 hours to conduct an initial assessment and clarify discharge instructions. These were either face-to-face, via telephone, or Skype. The case managers conducted 3 follow-up calls until the end of the 30-day period. Next slide. Phase 3 introduced Dialysis Link, which is a 24/7 centralized call center to exchange information between the providers during care transitions. The clinics placed calls to Dialysis Link when a patient was being admitted or discharged, and the operator coordinated with the hospital to assure receipt of information via fax or secure email. Next slide. In terms of results, the control group had a 30-day all-cause readmission rate decline of 18%. The right track, or the intervention group, had a decline of 26%. So, although the decline was greater in right track clinics, the difference in decline between the 2 groups was not, I think the next slide, yeah, go through these. This is the readmission group that you're looking at. This is the right track group. It went from 0.88 readmissions per patient year down to 0.65. And then the next slide. Okay, so you can see the control group went from a -8 or 18% decrease. The right track went from had a 5% decrease, but this was not statistically significant, and we think that that was probably because of the small numbers in the control groups. Next slide. Okay. We also looked at the general hospitalization rate, even though the project was designed to reduce readmission rates. There was an 11% decrease in hospital admissions in the control group, going from 2.14 hospitalizations per patient year to 1.9. And next slide. In the right track clinics, the decrease was 22%, going from 2.51 hospitalizations per year to 1.95. Next slide. And the results between the 2 groups here was statistically significant. So there was a the effect basically of all the interventions did have an impact in the control, or excuse me, the intervention group. So overall, we will be publishing some of the results of this project, but our project confirmed what others have found, that primarily there are critical processes of care that need to be modified to impact readmission reductions. Working on care transitions is hard and complex, and CMS seems to appreciate this. In the next network statement of work, which starts January 2016, CMS is calling for a small group of networks to assist them in developing a national project which can be rolled out through the networks in either 2014 or 2019. I hope that we're going to be part of that effort and we'll be able to bring our experience with the Right Track program and this project to the table. So the last slide, I'd like to acknowledge the Fresenius folks who are primarily responsible for this project, including Dr. Andy Howard, Rebecca Wingard, and Len Yusoff. So thank you for your time, and I'll be glad to field any questions now or at the end of the program.
Hi, everyone. We will now go back to Jennifer Payton. She has been able to join us. So, Jennifer, why don't you take it away?
Sorry about that. Can you hear me now?
Yes.
Okay, wonderful. So we're going to talk today about data from a study that was done on behalf of ANNA. If you've been on the other calls, you will have heard some of this data. It was a study in 2014. It was a patient safety culture in nephrology nurse practice setting. And the researchers were Dr. Beth Ulrich and Dr. Tammy Keir. And what they were looking at was the culture of safety in nephrology nurse practice settings. It was the first study of its kind to look at that. It used the AHRQ hospital and medical office tool. And it really shows that this is a subject important to nurses, nephrology nurses, because about 1,000 nephrology nurses throughout the U.S. responded to this study. Next slide. And there were, as I said, there were almost 1,000, 979 respondents. About 50 of them were not working in nephrology patient care at the time. So a total sample of about 929. We're going to go over these first few slides kind of fast just to give you the breakdown of who was in it. And you can see that we had not only managers, administrators, we had direct care staff, there were nurse practitioners, educators. So it really went across the spectrum of nephrology nurses, with about 52% being direct care staff in their primary role. Next slide. And it was not only chronic units that we think about out in the dialysis unit that we sometimes hone in and focus on them more, but it was 51.7% was in the chronic hemodialysis, but we also had 22% that were acute. We had inpatient units, transplant units, peritoneal dialysis clinics, medical offices, outpatient clinics. So it really kind of went across the spectrum. One of the big points that came out of this data really was interesting to me, as I'm currently a staff nurse working on the floor right now, where I've been a manager in the past and nurse educator and different administrative kind of roles. And it was very interesting to me that people that identified themselves as managers or administrators actually perceived patient safety much higher than that staff nurse who was working on the floor. And that's very interesting that, you know, kind of the people that are at the helm of this, you know, think that things are a little better than the people that are actually taking care of the patient. And this was in all aspects of patient safety. Next slide. We're actually now going to talk about handoffs and transitions. So the first one was in the hospital setting. So when the nurses were asked about shift changes, whether they were problematic for patients in the hospital, about 18% strongly agreed or agreed. That's the red and purple colors. Problems often occur in the exchange of information across hospital units. That was 37% of the nurses responded agreeing to that. Important patient care information is often lost during shift changes. That was responded by 25% agreeing to that statement. Things falling between the cracks when patients are transferring from one unit to another, that was approximately 35% of the nurses in the hospital responded to that, agreeing. Next slide, we're going to talk about the outpatient hemodialysis unit. And here here you can see the numbers are actually quite large, much larger in the patients, the nurses that are received. So problems often occur in the exchange of information between the hospital and the hemodialysis unit. That was my math went back from my brain for a minute, 52%. Things falling between the cracks when patients are discharged from the hospital to the unit, that's 60%. Things falling between the cracks when patients are admitted to the hospital, it was 48% agreeing to that statement. And things falling between the cracks when patients go to the emergency room, and that was what Derek was talking about earlier, and that's over 40%, about 45% agreed to that statement. So you can see that there really is, our nurses, you can go ahead and go to the next slide, that our nurses really do see that there is a problem with handoffs and transitions in taking care of our patients. And these are just a couple of statements that were made, comments that were made in the study that nurses really wanted to talk about this issue. And they said that communication was a problem across all settings, such as between hospitals and clinics or office settings, and that there's a lack of post-hospitalization report from the hospital to the dialysis unit. They state that there's a problem with follow-up between the hospital and the unit for a patient with peritonitis. And then another nurse stated that staff members often leave the treatment area without telling another staff member. And that's right there in the unit. You know, what's going on with this patient? Do we need to be watching for something when you've walked off the unit? And now we'll move on to the next. Thank you.
We will now hear from Cynthia Kristensen.
Hi. Can I get the slide there? I'm Cynthia Kristensen. I'm a retired nephrologist. I was with Denver Nephrologists for many years prior to last year. I'm still active with the ESRD networks and with the forum of the ESRD networks. And I think most importantly for this call, I was the lead on a Transitions of Care Toolkit sponsored by the forum. Next slide, please. The toolkit, good, there we are, is in the process of final review and will be posted to the forum of ESRD Network's website as of next month. So this thing about draft not to be distributed or shared will be taken off of there at that point. Next slide, please. The toolkit addresses transitions that were reported by patients, providers, practitioners as being challenging. This was based on surveys that we did in 2012 and 2013, again, of patients, providers, and practitioners. Transitions between settings were reported as the greatest challenge by practitioners and providers, and that's what we'll concentrate on here. Patients actually had other concerns about transitions between settings or transitions between modalities and other things, and even shift changes. Importantly, the suggested solutions in the toolkit are actionable by a dialysis facility. They don't require additional resources or major policy changes, and it should be possible to implement them on a local level. We wanted something that the dialysis facility could do and not a pie in the sky kind of thing. Next slide, please. I'm not going to read all the slides. You all can read. The slides that I have show just a sampling of some of the problems that were reported by providers, practitioners, and patients around transitions between settings. Some of these problems apply not just to hospitals, but also to other settings, such as a skilled nursing facility or a long-term acute care facility. And the problems are really perceived by all parties, not just by nephrologists. Next slide, please. both the admission and the discharge processes are a problem, that we often focus on the discharge processes and the fact that nephrologists are often not involved, and even if they are, they may not communicate with the outpatient facility. What I didn't show here, though, is that the problem is the problem that the dialysis facility may not communicate well with the hospital. Sometimes that's due to barriers in communication, and sometimes it's due to a failure to even try. I think Derek alluded to the issue of faxes being sent and nobody seemed to know where they were. Next slide, please. We're all pretty hyper aware of, see the next slide? Yeah, thank you. We're all really hyper aware of medication errors that occur at discharge. They also occur at admission because of inaccurate lists or no lists being sent to the hospital. Many of the discharge medication problems that we see are compounded by the lack of timely and accurate medication reconciliation following a discharge. But obviously there's a lot of steps in that medication process that where things go wrong. Next slide. So some of the recommendations that really come out of the toolkit are that many of the one of the first basic thing is that many of the communication problems are systems problems. They're not just problems of an individual being lazy or irresponsible or something. They're systems problems. It will really fall to the dialysis facility to create systems that will promote communications. Next slide, please. So again, it really falls to the dialysis facility to take the lead in the effort to improve communications during transitions. We're just a tiny part of the hospital's work, and the hospital personnel may not have any idea about what goes on in a dialysis facility. We're really not very high on their radar screen. And moreover, hospital EMRs are pretty poor conduits for communicating issues specific to dialysis patients. And we know that many nurses and physicians create workarounds to get past the issues of the EMR inadequacies. Next slide, please. We know that it takes a lot of work, as Nancy said, that it really takes a lot of work to create the systems that are needed for effective communications. And it doesn't really help that the people taking care of the patient change from hour to hour and day to day. So the person who's there at 2 o'clock may not be there at 3 o'clock. The physician there on Tuesday is not there on Wednesday. The hospitalist turnover. So there's a lot of barriers, and we need to create systems to overcome some of those barriers. And those processes really need to be created collaboratively with hospital personnel. Things that can be done kind of day in and day out. Next slide, please. So just a few of the specific recommendations in the toolkit are shown here. Some of them really start when before the patient even is going to the emergency department or the hospital. The facility needs to know where the patient is, and the patient needs to let the hospital know where they get their dialysis. That can be an issue. Most facilities already have protocols for sending the information to the hospital. However, as we heard, just because the information gets to the emergency department, it doesn't mean that it will find its way to the nursing station or to the acute dialysis nurses. And the dialysis facility often will probably need to take the initiative to send it to all of those places. Next slide, please. So communication processes really need to be established with the hospital discharge team and the dialysis facility. Often this means working most closely with the discharge planners or the case managers, since the hospital physicians change from day to day, as may the nephrologists. And the discharge planners can be really insistent and take the lead, requiring that the nephrologist be included in the discharge planning and the instructions for the patients. And so they really need to be used. And if they're not available, a charge nurse or someone else who has some continuity from day to day needs to be involved. The Another thing is to keep up communications with the inpatient dialysis nurses. You may not find out from anybody else that a patient can't sit in a dialysis chair for 4 hours or can't transfer from the wheelchair to a dialysis chair without a Hoyer lift. And the other parties that need to be involved here are the caregivers, the family. The family can really help, the dialysis facility, understand what's going to be needed post discharge, and they may be able to intervene at the hospital to encourage them to get home health care services. Next slide, please. I think we want to educate the patients and their caregivers before a hospitalization occurs. They need to know about keeping medication lists and keeping all the providers on the same page. You kind of hate to dump this on the family, but their involvement can really be helpful. Next slide, please. And then one of the let's see, yeah. And so again, don't forget the caregivers. They are very effective advocates for the patients. The dialysis facility may have limited influence over hospital actions, but the caregivers can be educated to help intervene. And we know that if patients are having repeated hospitalizations, their resilience kind of declines, and they may not be able to stay engaged. And so again, we need to really rely on caregivers, and they need to have the same problem lists and medication lists that the patients have. And remember that they can burn out too, so you got to take care of them. So really the final thought here is that we need to develop systems to work with hospitals and other facilities for communication and collaboration. And I think that's kind of what we need to focus on, is what kind of systems we can develop. So with that, I will turn it over back to Renee for discussion and questions and wrap up.
Thanks, Cindy. So, I think that this transition nut is probably the hardest one for us to even imagine how to go about slogging our way through, because it impacts our patients as they travel to so many different sites. And as the group has said, we don't really have a good handle on those transitions, and I think the nurses' safety survey has demonstrated that quite clearly, because on a day-to-day basis, the frontline staff is telling us that as hard as we're trying, it's an area that continues to put safety at risk. And as Derek taught us, it's an area that has, unfortunately, significant and potentially devastating consequences on our patients. So I think that as we think about things we can do to move forward, we might think about ways to share best practice and to use toolkits and to think about things that we can do as a group. And as we've talked about throughout these webinars, one of the reasons for calling this group together was to try to think together about whether we can define areas of risk within units, and then think about things we might do to work together to focus our attention, to leverage all of our resources and all of our brain power, and could we join forces. And so we have a couple of poll questions that we'd like to get people thinking about, because as we talk about transitions and transitions of care, we wanted to think about whether or not there might be things that we could learn from one another, and could we leverage that together, and are there things we should think about moving forward as a group to focus our attention. So we were curious about two questions tonight. Before we ask the poll questions, we're curious about what the stakeholders on today's call think about transition, and what you might share with us about the challenges you've had and the tools and resources you've used to mitigate them. And then after that discussion, we'd like to poll the group about maybe next best steps. So if there are any conversation or questions for our panelists tonight, let's take those first.
This is Alan. Maybe I can start off while others are raising their hand. I have a question first for Nancy. Nancy, that was an interesting model that you guys and Fresenius used, which basically was having an intermediate agency that facilitated the communication. So my question is, number one, has that continued? Is it thought to be useful? Do we know whether the caretakers on both sides of the care equation find that useful? And what's happened with the with that pilot?
Alan, Dialysis Link is a program that Fresenius has, and it's not designed for care transition. So it was just sort of retrofitted, if you will, for this particular project. And no, it has not continued, which is unfortunate. I don't know that it was all that successful, and I got to tell you, from my perspective, we need an IT solution to this. Faxing this stuff is not the way to go. We need to be able to access medical records from the hospital to the dialysis center. And I think we also investigated using the health information exchanges, but in the state of West Virginia, they weren't sophisticated enough when we were doing this project to be able to tap into that. And I don't know that they are across the country yet either. But that to me seems to be the solution down the road. The other interesting thing from my perspective is that CMS is looking to redesign some of the IT stuff for the dialysis or the ESRD world. They're putting together something called EQRS, which is ESRD Quality Reporting System. It's going to be a merging of Crown Web, REMIS, and the QIP program. And they're going to find a contractor who's going to work on this. And I think it's going to be pretty important for the community to try to get involved in this and see if we can't make sure that care transitions is front and center in this redesign, and to try to figure out some way to incorporate that.
Yeah.
Nancy, this is just Renee. As a segue from that, do you foresee CMS being helpful in terms of the HIPAA regulations between dialysis units and hospitals to make that a more seamless exchange of information?
Well, you know, there's all sorts of agencies involved in this, so I think it's going to be challenging to get those other agencies on the same page. But I do see that CMS is going to have to move in that direction and take leadership. And I think the idea that they're going to put together a group of networks who will design a national project, I think it's going to be sort of like the Fistula First Breakthrough Initiative, is from what I'm reading. So I think there is some hope there that you know, they can take the leadership and do some of this.
Be great. And do you know which networks this is, what the plan is yet, or is it too early?
No, it's too early. They haven't even awarded the network contracts yet. I'm told that they're going to do that and make an announcement at the Quality Net meeting or Quality Conference they're having December 1st. So hopefully they'll tell us before we all get in the same room, you know, which would be nice. But as soon as they do that, they say they're going to select 5 networks who will work with them on this. And I think that there'll be lots of networks who will submit proposals to do this. We will be one if we're still up and running.
Can I ask Cindy a question?
Yeah.
It sounded from what you talked about that you're thinking in terms of a toolbox, I guess. And from the presentation, I gathered that you were suggesting sort of a template transfer sheet, perhaps similar to what many of the LDOs currently are recommending. I just wonder, beyond that, you had sort of some general recommendations about communication and patient involvement, et cetera, but did your group have any specific recommendations or specific tools that it thought would be useful?
Well, in the toolkit, in the appendix, we did include some tools that other, you know, you know, providers and practitioners are using, and I think that there are so many different kind of practice models out there, even within the same, you know, physician group sometimes, that I think anybody's going to have to individualize the templates that they use and the methodology that they use for getting the information back and forth. I think it'll be great when we do have, you know, electronic medical record systems that communicate with each other and that do have dialysis specific information. I don't know of any. I'm not familiar with any right now that are real useful in that sense. But again, we have some templates in the appendix that just will have to be, I think, individualized.
Do you think there'd ever be the possibility of standardizing that template across the continuum of dialysis, so that we could all have one shared baseline template?
I don't know. I mean, I know even within the group that I was within Denver Nephrology, and we were a 30 nephrologist group, and we had difficulty coming to any kind of agreement as to what needed to be in the transfer forms. And so there were kind of wide differences of what people considered as important information to communicate at the time of discharge. So I think that will be a challenge to even have agreement on what needs to be done. And the other issue is time, because it takes time to go back to the hospital record and figure out those details. That's why I think that it'll be important for the electronic medical record to be very have a lot of specific information about dialysis, so that the dialysis clinic even can look up to see, well, was the EPO given on dialysis, or was the patient receiving it, at some other point? I mean, I think there are a lot of little details that are very specific to whatever the setting is, and rather than requiring the nephrologist or nurse practitioner to have to go back and try to gather all that information, if the dialysis unit can just see what was going on, that would be very helpful. Kind of a long-winded answer, but I don't know that we're going to be able to come to a standard, to agreement across the board as to what little bits of information need to be put together in a form at the end of the hospitalization.
If it's any example, here in New Haven, our Yale system has a wonderful, robust EPIC system. We have both Vita and Fresenius patients who come to the hospital, and we send back, each of which has a wonderful independent system. None of the three talk to each other, and none of the three can share any information together. So it's as if we're still in the 1980s here in the year 2015.
Well, and think about it, too. One of the things I brought up is that who's going to know if the patient even could transfer from the wheelchair to the dialysis chair in the acute unit? And so there's lots of little pieces of information that we need to be able to look at, and that may not be something the nephrologist can put in a transfer summary, because they may not know either.
Right.
So I think there's got to be a way of looking at those little bits of information without having to spend on a transfer summary each time.
If
I
we
can't
can
help
get
but wonder
to
if it
standardize.
Right, if it isn't our responsibility, the nurses and doctors taking care of these patients, and patients like Derek, to be able to get together and to identify those. There are some things that are particular for dialysis patients that always have to be shared. Yeah. Things, as you say, not only medications, but mobility and transfer and transportation, there's just. It would seem to me it wouldn't be very hard to identify a core of share information that really is critical, particularly for dialysis patients.
Well, if you could, and I don't know who's going to be working on the dialysis specific stuff in hospital EMRs, but if there was, it seems to me like there would need to be a way for the electronic medical record to group that information. I mean, it can pull information from all kinds of different places, and that you need to be able to then have a template where all that information gets gathered electronically.
Right.
And
so that
someone's not, so that a person isn't having to go through and piece all that together.
So maybe
that
it does. And to Alan's comment, dialysis units aren't part of meaningful use, and the care, because of the EMR, is enormously fragmented, maybe worse than ever, because we can't access them. They don't speak to each other. The data are all in different places, and none of them are integrated in any way. Maybe magically, as part of our safety initiative, maybe it would be possible for a group like this, a large stakeholder group, who would then team up with others to actually create, I know it may be like pie in the sky and Pollyanna, but maybe you could create an agreed upon template that every EMR, because obviously we all use them all, would incorporate, and it would get sent to the dialysis unit electronically or maybe through the cloud, since all this is going to have to go through the cloud eventually. And we could all have, as an initiative of saying, we're done with this nonsense, we're done with the fact that we can't communicate, and maybe we could drive that bus. It's, one of the reasons we wanted to come together was the issue of, could we collectively empower ourselves to try to do something to focus on an issue, a topic that might dramatically improve care.
Well, Lou Diamond is working with a health information technology. Nancy may know a lot more about it than I do. I just know bits and pieces. But is working with kind of a coalition to develop, information technology. I think the first step is to kind of share between dialysis facilities, and then the next step, I think, is to be able to communicate with hospitals. But it may be up to this group or a similar group of stakeholders to as the people with the feet on the ground, to work with that coalition to say this is what we need to put together. These are the pieces of information that the dialysis that need to be pulled together in an EMR, so that they can be transmitted between facilities and between institutions.
So
Hi,
that might be. Oh, go ahead, sorry.
Sorry, I just wanted to say that it seems like one of the other opportunities is something that Nancy was mentioning earlier. If they really are going to be trying to merge together their IT systems on the ESRD side a little bit better, instead of each one of us or different organizations speaking just from their hat alone and their position in terms of, this is what we've done in the past and this is the way we like it, there needs to be some way of maybe now getting all of our colleagues, if you will, in agreement, at least to make a collective recommendation that this standardization has got to happen sooner than later, and they can't come to the table just promoting their own corporation viewpoint. Something has to be done to bridge this so that we can all agree that this frustration just can't go on. It's detrimental to patient care.
Absolutely. So maybe that's a nice segue to the poll question. We have just a few minutes left, and so we thought that since this is our final section of the webinar, so we've covered a variety of topics, and we thought that we should ask the group whether or not we thought that it would be possible to leverage and prioritize our efforts, and if we did so, what topic should we focus on, say, over the next 6 months. And these are the 4 topics that the webinars covered. We talked about establishing a culture of safety, medication reconciliation and management, infection control, and as we heard tonight, transition to care. So if people would just take a second and think about that, of whether we would like to leverage our expertise. If so, which of these topics would we address it towards? And so 67% thought we should begin by establishing a culture of safety. No one thinks medication or infection control would be the place to go next, and 33% thought transition of care issues. That's very interesting. That makes sense. Maybe you need to start at the top and first have a culture of safety before you can accomplish anything else. And
let's remember that represents, I think, 3 votes.
It does, less. So 2 out of 3 think that, right? I didn't want to say that, Alan, but good job. Small vote. This won't be the sticking poll. And then to that same small group, we wondered on the next question. Now we'll know if we're unanimous or not. We took that bold step of saying, do you think we could create a roadmap for our facilities to achieve specific patient safety benchmark milestones? And of those 3 respondents, the question is yes, probably not. There are too many competing factors, or no, my facility is already as safe as it can be. Now, were there no names attached to this? Honesty is always the best policy, so a few of us think that it's just too many competing factors and maybe it's not something we could take on, and 80% thought that there would be some hope about that. So I wanted to ask Alan if he'd like to give us a couple of thoughts about maybe next steps and things we can do as we're closing out the webinar series. The good news is it looks like we have some topics we could focus on, and it looks like there may be a stimulus to do that. So Alan, you want to give us some closing ideas about what your thoughts are of potential steps? Yeah.
Well, first of all, I really do want to thank all of the people who participated, not only presented, but everyone who came and listened. As I look at the names, there are some silent stars that have been at every single one of these, even if they haven't said much. So I really want to thank everybody for participating. This is really important work. And I think as you sit back and think about over these 4 webinars, what we've learned is that we surely have a task ahead of us. And we've had some specific recommendations and some ideas, but I do think we need an opportunity to look carefully at what we learned in these community discussions, and perhaps then come up with a sort of a plan going forward. And so what I think we're going to do is ask the steering committee and some of the regular participants that have been on most or all of these calls to help together to talk about what we've learned, what next steps might be, and kind of what measurable goals might be for us. Something that I'm hoping that we can arrange sometime in the next few weeks before these lessons we've learned start becoming ancient. So that's what I'm hoping the plan is going to be.
Sounds great. And I wanted to echo your thanks to our panelists today, and to the stakeholder group and all the people who've participated, and especially to Amy and Dale for having this opportunity for us to get together, and to thank you, Alan, for all of your good guidance and hard work, and to thank all the people who've participated in trying to improve safety for our patients and our staff.
And before we let everyone go, I would like, on behalf of the Renal Physicians Association, to also thank everyone for their participation. This is really an exciting area for us to continue to pursue, and as a community, we look forward to working with each of the groups that have participated and the representatives of those groups to move this agenda forward and to improve kidney patient safety. So thank you, Renee, thank you, Alan, and thank you to everyone.
All right, thanks. So, Alan, we'll look forward to next steps.
Thanks, everybody. Bye-bye.
Thank you. Bye-bye. Have a good